Hello, my name is Alberto Oriol. I work at the Institut Català d'Oncologia, Catalan Institute of Oncology in Badalona, near Barcelona, and I'm also investigator at the Josep Carreras Institute. I'm going to talk about the KARMA trial. The KARMA trial, it's a very relevant trial in multiple myeloma for relapsed and refractory patients, because it's the first phase 2 trial with solid data regarding the use of CAR T cells against BCMA for patients with multiple myeloma. The patients that were included in this phase 2 trial were basically patients that were basically refractory to every conventional therapy, triple, quadruple refractory to most available agents, including proteasome inhibitors, anti-CD38 antibodies, and IMiDs. So that's a very difficult population to treat. Additionally, these patients had had about a median of 6 prior lines of therapy. Most of them had aggressive disease with high-risk cytogenetic characteristics, plasmacytomas. So it was a particularly bad population. Results of most investigational drugs used in this setting give responses in about a third of the patients, and the duration of these responses is about 6 months. In contrast with this, with the CAR T-cell therapy, we achieve responses in almost 80% of the patients. A third of the patients achieved a complete response, which is particularly outstanding. And the median time to progression was about 8 months. But if we take into account this third of patients that had a very good response, a complete response, it's about 22 months. So that's and a big step forward in comparison with the kind of drugs I mentioned before. Why is that trial so important? There's 2 reasons. The first one is that we have proved that in the relapse and refractory setting, in a very difficult to treat population, CAR T cells work in multiple myeloma. That's an important point. The second important point is that as 10 years ago, we used to use the drugs sequentially. We used bortezomib and then lenalidomide and then pomalidomide and then carfilzomib. Now we are tending to improve efficacy combining these drugs. That means that we use a combination of 3 to 4 drugs frontline, and that implies that good risk patients obtain a very prolonged time to progression and a huge benefit from treatment. But the small proportion of patients that do not respond well to this treatment or respond for a very short period of time, they have not good options at relapse, because they usually use alternative drugs, again, a triple combination of drugs, not the same drugs used before. And then time to progression goes between 8 and 18 months. So that means that patients that do not go well with a first-line treatment usually obtain also limited benefit from a second-line treatment. So very soon, these patients that are treated with combined treatments reach a point where they have used every drug available, and they obviously need alternative therapies. These alternative therapies come from basically immunotherapy, bispecific antibodies, and CAR T cells. So this CAR T cell is the first one we have available. FDA has already approved the drug. And for this particularly difficult to treat population that we are going to find earlier in the course of disease, because we are using drugs in combination, so are exhausting conventional therapy sooner. Limitations of the study. As you see, it's multiple myeloma is not like acute leukemia or lymphoma in terms of benefit of CAR T cells. Myeloma is a very resilient disease. So once the CAR T cells are exhausted, myeloma can relapse, and in fact it relapses. So we still have to find a way to make CAR T cells more durable, And we may achieve that by using CAR T cells before, not in patients so refractory and exposed to most of the drugs. And also we have to think about ways of maintaining the effect of the CAR T cell beyond 1 year or 2 years, which is the median time to progression for patients that respond to CAR T cells.